I always like to start with the less routine injections first. So, you treat glabellas all day. This is a little bit rarer, so I'm going to do that first while I'm thinking about it as a special area. We're going to do 3 injections. Now remember what I said about depth here. This needs to be superficial. It might be a little bit safer if you're angled slightly away from the eye until you've got your anatomy really dialed in. So superficial injection just underneath, and I only need to go just basically underneath the dermis, and the dermis is super thin here, so it's probably about 0.2 of a millimeter. This does not need to be a deep injection. So I'm gonna just pop in like that. That's it. Elevate the skin. You can see a little bit of blanching. That's a good sign I'm in the right place. And that's just 1 unit. Same again. There we go. 3 injections just underneath here. I sometimes just want to make myself feel safer by rolling away from the eye. I don't think it does anything, but it feels better. There's a debate always about whether you should be pointing away from the eye or towards the eye. When you first start, I think you should definitely be pointing away from the eye, because it just gives you a bit less leeway, a bit more leeway if you make a mistake. The biggest issue is that people go too deep. They create a track. Even if they come right out to the right place, they end up with a path for botulinum toxin towards where you might get a side effect. So it makes sense to inject in a direction where even if you go too deep, it doesn't matter. So here, if I go too deep, I'm just treating temple. There's nothing really there to cause any issues. So a little injection just here, 2 units. You can also stand on the other side of the bed and lean over your patient. So next injection point, we're going to do the glabella. So the glabella is a risk for eyelid ptosis, and one simple step I recommend you doing is just putting orbital pressure. So you basically squeeze the tissue where the tract would have to be in order to get botulinum toxin into the orbit. So a little bit of pressure here. And the next thing is just remind yourself of the anatomy. The bone is the origin of the corrugated supercilii muscle, and it's going towards this insertion point, and that's actually how the needle should follow. So this is the easiest way to be accurate, is to aim for the largest shape. If I'm aiming from inferior or superior, I have a smaller area of that I can be safe in. This is much safer, because even if I'm slightly a degree or 2 off, the muscle is basically going to capture it. So insertion point here, it's a relatively deep injection to start with, 4 units, pressure on the globe, and then you do the lateral injection, 3 units, intermediate depth, I'm not as deep, and then superficial, right at the end, 1 unit. A little lucky roll or bit of pressure away from the eye. Would you like to try that on the other side?
Yeah.
So forehead injections are actually the easiest technically, because we spent so much time creating a safety margin here that basically the skill bit is done, and the injection works pretty well no matter what you do here. Now there are some nuanced differences, which is if you inject intradermally and you get a little white bleb that forms, then you're not going to get as much of a result, because you now got botulinum toxin sitting in the dermis, which is then underneath the dermis. You have the hypodermis, which is a layer of fat, then you have the muscle fascia, then you have the muscle itself that you're trying to treat. So you're separating it away from the effective area. A paper recently came out from Sebastian Cotofano which talked about more effect going deep rather than superficial, but I've never actually seen anyone inject that superficially that they're getting white blebs, because it hurts. For one thing, you get more pain because there's more pressure in the dermis, and you see a white bleb as you squeeze the blood out of the skin. So what I'm actually normally trying to do is hit the muscle itself, which means I go through the dermis, which basically feels like resistance, and then it suddenly eases. And then I go a tiny bit more, and imagining that to be basically in the muscle, basically just through the fascia, which is where most of the nerve endings are, and that's where I inject. If you go deeper and touch the bone, that's fine. But the problem is you blunten your needle every time you touch the periosteum. It doesn't hurt as much as you'd think, but I prefer just trying to hit the muscle. That's just my thinking on it. So I'll demonstrate what I do. It's about 45-degree angle of entry. Once again, I'm not actually trying to inject here, I'm just injecting underneath it. So I'd be going in here and doing 2 units just through the dermis and stop. Pretty straightforward injection. 2-2. Now you should always clean these little blood spots off as you go because they're much harder to remove once they dried on. And in a busy clinic, it actually saves you about 5 minutes, which is a lot. Very simple, we're now just repeating the same thing again. 45-degree angle of entry. As you inject, feel resistance, and then it gets slightly easier. Two injection points. You know you're in the right layer because it doesn't blanch. Blanching is not good. So this is a good example. I've hit a little vein here, and every time I release to check if it stopped bleeding, it just keeps bleeding. So I've now made the mistake. I'm not going to check again. I'm going to hold it for a full minute. Because although this is never going to be anything but a small bruise, I try my best to keep bruising to a minimum because I'm just all the time trying to aim for this being a seamless, easy process for my patients, not having to put loads of makeup on to cover a little bruise, not having a little sore spot. So it's worth spending at least a minute just holding this. Finally, we'll do 2 quick little 1-unit doses here. That's the forehead done.